Assalamu alaikum. My name is Mohammed Diab, and I'm an emergency physician at the National Guard Hospital. So today my talk will be on approach to drug-induced QT prolongation. So this talk, you probably know how to manage drug-induced QT prolongation, but I hope that at least most of you will have one or two new things to learn, to take home from this talk. So we'll begin with a case scenario. So the usual, overdose patient, a 32-year-old male ingested an unknown amount of a medication 8 hours ago, comes to your hospital, to your emergency room. He's somnolent, but arousable. His vital signs are normal. You do an EKG, and you find he has a QTc of 560. We all have encountered these situations. What we usually do is we put them on a monitored bed. We consult like a toxicologist, and until the QTc is back to normal, then we either discharge them or, at least put them in a non-monitored bed. So it's a reasonable way to deal with patients. We're doing okay, but can we do better? So in this lecture, we'll try to answer these 6 questions. So first, how would we, quantify the patient who will develop TERSAD or not from QT prolongation? Which drugs are associated with a high risk of TERSAD? And then how would you measure the QT interval? How would you give prophylactic magnesium sulfate or not? And what electrolyte would you optimize, and how would you deal with TERSAD? So before this, we'll go into just a brief basic introduction. So what's the QT interval? We all know the QT interval is between the beginning of the Q wave till the end of the T wave, right? And it represents the action potential of the myocardial cell. So a prolonged QT means a prolonged action potential, which could be from 2 things in toxicology, either from a sodium channel blockade or from a potassium channel blockade. So sodium channel blockade will cause a prolonged depolarization, which will be reflected in a prolonged QRS on the ECG. A potassium channel blockade will cause a prolonged repolarization, and which will be reflected in a prolonged T wave in the ECG. In medicine, usually, when we talk about QT prolongation, we usually mean the second one, the potassium. We usually mean a repolarization abnormality, okay? And in toxicology, when we talk about drug-induced QT prolongation, we usually mean that the drug is causing a potassium channel blockade in the myocardial cell. We call this channel the delayed rectifier potassium current. We all know that QT prolongation is important because it can lead to TERSAD it can lead to early after depolarization, which can degenerate into TERSAD. And I just want to mention here that TERSAD is usually an arrhythmia which is short-lived. So for 10 to 20 seconds, and then it goes back to sinus rhythm. Sometimes it degenerates into VFib. So when it happens, and then it can go back to sinus rhythm, but it can happen and then it degenerates into VFib. So the first question, how would you quantify the risk of developing TERSAD from a QTc prolongation? So who would use the absolute QT? Raise of hands. Who would use the corrected QT, QTc? Okay. So the rest would use the QT nomogram? Yeah? Okay, well, so I'll compare your answers to toxicologists around the globe. This is a paper done in 2014. It's a survey that surveyed medical toxicologists in the States and in Europe and Asia about how would they manage drug-induced QT. Most of them answered that they would use the QTc. Only 3.1% answered that they would use the QT nomogram. Now, I would try to convince you that the QT nomogram is probably the better way to deal with this. So let's see. So first, why do we correct for the QT? We correct for the QT because we all know that the QT is affected by the heart rate. The faster the heart rate, the shorter the action potential, shorter QT. The slower the heart rate, the longer the action potential, and the longer the QT. So you need to correct it to a heart rate of 60. We all use the QTc, we all use the Bazette formula for correction, which is famous. It's the QT divided by the square root of RR. And when we have a QTc of 500 milliseconds or more, we consider that as significant for development of Torsades. But what's the disadvantages of the Bazette formula? So it has been criticized that it overcorrects at slow heart rates, thus underestimates the risk of developing Torsades, and overcorrects at slow heart rates, so it will underestimate the risk of Torsades, and undercorrects at faster heart rates. So it is, although it is conservative for tachycardia, it will underestimate the risk of developing Torsades at bradycardia. And you have to believe me this, but if you look at the equation, you can know this. If you have a big RR interval, bradycardia, you will have an overcorrection because the whole, this part of the equation will be smaller. And it is at slower heart rate where the risk of Torsades is increased. So we have a problem here. So the QT nomogram is a simple nomogram, simple tool. It's just like the Romack-Matthew nomogram for paracetamol toxicity, for example. So you have here the y-axis. This is the absolute QT interval, not the corrected, the absolute QT interval. And then you have the heart rate. So you just plot the absolute QT interval with the heart rate. And if the intersection lies below the nomogram, the risk of developing Torsades is negligible. So it's okay not to put the patient, for example, in a monitored bed. But if the intersection is above the nomogram, then there is significant risk of developing Torsades. So what's the evidence? This is the derivation study that was done. It's a study that compared basically the QTc using the Bazette at 500 milliseconds with the QT nomogram. So what did they do? So they basically did a systematic review of the literature, and they took 138 cases of drug-induced Torsades, which is represented here by the triangles, and the controls were basically patients who overdose on non-cardiotoxic medications, which are basically the circles. Now, as you can see, this image here is the QT nomogram. This dashed line is the Bazette QTc at 500 millisecond nomogram. Now you can see both of them actually picked up most of the drug-induced Torsades, drug-induced QT prolongation, which developed Torsades. But if you look at the Bazette, it's actually missed a lot of cases down here. So it missed, these triangles are cases of drug-induced Torsades. So it's clear from this picture that the QT nomogram seems to be much more sensitive. And here's the numbers. So sensitivity, 96.9% of the QT nomogram compared to 93.8% for the Bazette at 500. Specificity, 98.7% versus 97.2%. So the QT nomogram missed only 5 cases of Torsades. And from this study, actually, what you can see is that most Torsades happened in patients with low heart rate, so bradycardia. Only 7 cases happened in patients with tachycardia. This tells us that bradycardia is a risk factor to develop Torsades. So if you have the same degree of QT prolongation, if you're bradycardic, you're at more risk of developing Torsades than if you're tachycardic. And why is this important? Because if you look at the picture again, you can see that the QT nomogram and Torsades almost have the same shape. They only differ and diverge when the heart rate is less than 60. The QT nomogram becomes more conservative. It has a straight line, so it picks more cases, whereas the Bazette continues upsloping. So this is why it's important to know that the QT nomogram is much more sensitive than the Bazette. And it's also easier to use. You don't need to correct anything. You just plot it on the, the absolute QT. You can calculate yourself or the machine, and then with the heart rate. So was it validated? There was at least one validation study on amisulpride overdose. Amisulpride is an atypical antipsychotic with a sensitivity of 100%. So the second question, which is related to how to quantify the risk of developing Torsades, is which drugs are associated with high risk of Torsades? So if you have 2 drugs that, let's say, produce the same degree of QT prolongation, it does not necessarily mean that they have the same degree or risk to develop Torsades. And I can't really give you like a logical framework to work on why this happened. Fortunately, you have to either look it up or ask like a toxicologist. But for example, antiarrhythmics, like 1C and 3 antiarrhythmics, they cause QT prolongation, but they also have higher risk of developing torsade than psychotropics. In psychotropics, for example, amisulpride, typical antipsychotics, phenothiazines, methadone, cause QT prolongation, and they have a high risk of causing torsade, versus, for example, atypical antipsychotics like olanzapine, risperidone, and quetiapine. They can cause QT prolongation, but for some reason, it's very, very, very rare that they cause torsade. And the reason probably is that the atypical antipsychotics have anticholinergic properties or antimuscarinic properties, and in overdose, they will cause tachycardia, which is actually protective against the development of torsade. Another thing worth remembering is that from the SSRIs, citalopram and its enantiomer, escitalopram, is probably the only SSRI that will cause significant QT prolongation, and there have been cases of torsade. So, in summary, when you quantify the risk of torsade, it depends on the drug. It also depends on the patient. I forgot to mention, it's his electrolyte and his comorbidities. Lower heart rate has more risk of torsade. Higher heart rate might be protective. And of course, the degree of QT prolongation, the higher, the more risk that you will develop torsade. And last but not least, use the QT nomogram. So the third question, would you correct it yourself, or would you use a machine calculation? So who would use manual calculation? Raise of hands. Who would use the machine? Okay. So the survey, 50% answered machine and 50% said they will do it manually. So what's the pros and cons? The machine calculation is easier. It's also reliable. It takes multiple ECG leads, take the average. But the problem with the ECG machine is that sometimes it cannot detect the end of the T wave. So if you think that the tracing is not clear and you have a problem with the T wave, then it's better to do it manually. So to do it manually, there's two methods. The tangent method, which is reliable and accurate. So you draw a tangent here and you take the intersection between this line and this line, but the visual method is more conservative. Here you can miss a couple of millimeters. So do the visual. I would do the visual method unless it's not the end of the T wave is not clear. Then I would do the tangent method. And it's recommended to take 6 leads, 3 limb leads and 3 chest leads, precordial leads. So lead 1 to AVL or AVF, lead V2, V4, V6, and then you take the median. The median is the middle number between all these leads. If you have 2 middle numbers, you take the average of them. And then you would plot it on the QT nomogram. So you don't need to correct it, just plot the QT nomogram with the heart rate. And if it's below the nomogram, the risk of torsade is not significant. If it's above the nomogram, then you have a significant risk of developing torsade. If you want to use a single lead, it's recommended to use lead 2. So the fourth question, would you give prophylactic magnesium sulfate in a patient with QTC more than 500, or in a patient where the QT heart rate nomogram is above the nomogram? So who would give magnesium sulfate prophylactically? And who would not give? Okay, so again, 50% of the survey of toxicologists answered they would give, and 50% said they wouldn't give, approximately. But yes, magnesium sulfate, there's no evidence that magnesium sulfate shortens the QT interval. The ACC/AHA guideline recommends that it should be given if you have torsade. Of course, if you have torsade, you have to give it. Unless, of course, you have hypomagnesemia, then I would correct it. So what about potassium? If you have a run of torsade and it's corrected now, and you gave magnesium, would you give potassium? First of all, would you keep potassium normal? Would you aim for a higher potassium? Or would you, even if it's low, you wouldn't care? So who would aim toward the high normal potassium? Okay, so most likely the correct answer is that you should aim for a higher than normal, for a high normal potassium level. Potassium has been shown to shorten the QT interval, and this has also been recommended by the ACC and AHA guidelines that if you have a run of Torsad and you still have QT prolongation, you should aim for a high normal potassium, between 4.5 and 5 milliequivalent per liter. So the last question, you probably all know this, would you do cardiac pacing for a run of Torsad? Meaning, would you keep now we know that tachycardia is protective, would you keep the heart rate above 100, either chemically or electrically? So a third of the toxicologists in that survey answered that they would do if it happened, if the Torsad recurred, and a third said they will do it even if it happened once. And the AHA guidelines recommend that you would do ventricular or atrial pacing to keep the heart rate above 100 if you have recurrent Torsad. I personally would do it even if I have one run, just to keep the heart rate above 100. So, in conclusion, risk of Torsad with drug-induced QT prolongation depends on the drug, depends on the patient, of course, and on the degree of QT prolongation. Use the QT nomogram to assess for the risk of Torsad. It's much more sensitive and it's easier. Of course, check for the electrolytes: calcium, magnesium, phosphate, calcium, potassium, and magnesium. Prophylactic magnesium sulfate, there's no evidence that it would help. Only give it if the patient developed Torsad. And also, if the patient developed Torsad, keep the heart rate above 100 and keep potassium high normal. Thank you.